Welcome to Oncology Today, new data sets and advances in non-metastatic non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Jamie Chaft from the Memorial Sloan Kettering Cancer Center in New York City. To begin, I asked her to discuss a real-world case from her practice.
So this is a 70-year-old male former smoker. He had a fairly heavy tobacco history, but had quit a few years ago. Regardless of that, he should have been screened. This is a perfect patient for CT screening, which has really been expanded with the American guidelines to enable screening for a broad population of patients with any sort of tobacco history. He was not screened, however. He presented with cough, which led to a CT scan showing this posterior parahilar mass. I think suspicious enough to lend itself a PET scan prior to diagnosis, bronchoscopic diagnosis. However, that's not always the case. It's not uncommon for our patients to undergo a bronchoscopic biopsy prior to staging, as techniques have really improved, particularly with robotic bronchoscopy, to yield adequate tissue from either the primary or the regional lymph nodes to ensure we can get all of the necessary molecular testing.
Can you talk a little bit about his workup, his staging, and also assays that were done to see his PD-1 was high?
Yeah. So the diagnostic guidelines really suggest that virtually any patient with a 2-centimeter central, 3-centimeter peripheral nodule in the chest should undergo invasive pathologic mediastinal staging. And while historically that was mediastinoscopy, now it's universally endobronchial ultrasound and systematic nodal sampling, both of the ipsilateral and ideally the contralateral lymph nodes. In terms of tissue adequacy and testing, for squamous cell carcinoma, our molecular drivers are less important. However, we'd still like to have them, particularly if it's a squamous cell carcinoma in a minimal or never smoker. But for all of our non-small cell lung cancer, PD-L1 really is prognostic and predictive for immunotherapy benefit, and it truly informs the discussion in the clinic, particularly if you're a little worried about margins if the tumor doesn't shrink.
So what was his clinical stage, and from your point of view, what were the options?
Yeah, so this is a T2N1 tumor. It's a little hard to differentiate if that's N1 or N2, but it's far enough away from the central vasculature that he was staged as an N1, so a stage 2 lung cancer. You could call it T3 if, depending on bronchoscopically how far it extends from the carina, but radiographically it's a T2. And options really depend on operability and resectability. So technical resectability, can a surgeon cut it out with clear margins? And then, of course, medical operability is the patient's lung function and cardiac function safe for the required surgery, which, of course, we hope to be a lobectomy or a bilobectomy and spare the patient a pneumonectomy whenever possible.
And what was the assessment of your interdisciplinary team? Was he presented at an interdisciplinary conference, but particularly in terms of resectability at that point?
He was felt to both be operable and resectable based on the posterior hilar location. It was not felt to need a pneumonectomy. Thankfully, that lymph node, it's not central, nestled in the hilum. It's actually the N1 hilar nodes that are often the most problematic. It's not the N2 nodes for most patients when you're thinking about pneumonectomy versus less.
I see he's a former smoker. How much did he smoke and how long ago?
He had quit well before diagnosis. I'm not sure what prompted him to quit, but he was a 40 to 50 pack year smoker, heavy smoker.
And can you talk a little bit about the options that you discussed with him?
So the options really are upfront surgery, followed by adjuvant therapy, induction therapy, followed by surgery with or without further adjuvant treatment, or concurrent chemoradiotherapy, followed by durvalumab with no consideration of surgery.
So can you talk a little bit about what happened to him?
Yeah, so he was amenable to induction therapy. He was treated with carboplatin, paclitaxel every 3 weeks, and nivolumab. At the time he was treated, this was our only approved regimen. And he had a really nice response in the tumor. However, experienced severe hypothyroidism. Now, the 3 versus 4 cycles of therapy is up for debate these days. With the Checkmate 816 regimen, 3 was what was planned. And despite this, you can see scintigraphically the pre and post, pre on the left, post on the right there. He had a really nice response in the tumor and lymph node, but developed hypothyroidism. So I think in terms of our patients receiving these induction regimens, we have to think a little differently after induction therapy. While it's uncommon, sometimes we see nodal flare as a response to immunotherapy. But more commonly, the things we really think about regularly are the endocrinopathies, because they can be particularly dangerous if the patient goes to the operating room with no detectable thyroid hormone.
So when exactly did this occur? Was this a clinical hypothyroidism or just you picked it up on blood work?
It was not clinical. It was, and we missed the hyperthyroid component, which you can often capture in these settings. You see the hyperthyroidism on his scan, but at the end of 3 cycles, when he had a post-treatment PET, I always check thyroid hormone and the adrenal axis, ATCH and cortisol, and he was hypothyroid, profoundly hypothyroid, by just 9 weeks after his first dose of nivolumab.
So what happened? Of course, the big question here would be adjuvant Nevo or not.
Yeah, so I mean, now an option for the 77T regimen. This patient had a complete resection. He had cleared his lymph node, however, had residual T1A disease left in the primary, so not a pathologic complete response. And he really struggled for months to get his thyroid levels stabilized and had some associated blood pressure issues, but really nothing major. But given the T1 tumor, he opted against further therapy, and we've been watching him, and he's been fine.
You know, it's interesting. Of course, I've heard so many cases presented to me of thyroid dysfunction, hypothyroidism, and I always assumed, and I never heard anybody say anything, oh, it was difficult to control them. But what happened? What was the problem here?
It was really hard to get his levels stabilized. He did not have adrenal axis dysfunction, which we often see co-associated with thyroid dysfunction. It wasn't a central issue. But for whatever reason, they struggled. The endocrinologists were involved. His surgery was delayed a good month until they could get some adequate levels of thyroid hormone in his blood. We have to, you think of thyroid as being easy, right? But in our patients who are smokers, we worry about their hearts and stressing them after they've been hypothyroid and generally titrate up very slowly. But you want to make sure that those levels are adequate before inducing anesthesia.
So I'd like to use this case as a way to sort of get into updating our audience on the trial data that's out there and that's come. There's multiple IOs that have been tested in this setting in different ways. You have to be kind of a Talmudic scholar to go through all these trials and figure out what's similar, what's different. I'm hoping you can sort of capsulize a little bit about what we know about treatment in this situation, and also include, I'm also curious about the potential role of ctDNA in this setting as well. So can you talk about kind of like summarize a little bit about where we are in terms of the data relating to, I guess, neoadjuvant, adjuvant, perioperative IO chemo?
Sure. I think at a high level, the game changer was the first study, which was Checkmate 816, which was 3 cycles of neoadjuvant chemoimmunotherapy and no additional adjuvant therapy, really dealer's choice adjuvant therapy. Checkmate 816 increased pathologic complete response and EFS and has subsequently demonstrated OS in the secondary endpoint fashion. So really impressive hazard ratios in the 0.6 to 0.7 range in terms of overall survival, with durable responses and overall survival at 5 years now published. We have since had 6 perioperative studies. So perioperative meaning preoperative chemoimmunotherapy. All of them studied 4 cycles with the exception of one study done largely in China, followed by either a year or the completion of a year of adjuvant checkpoint inhibitor or associated placebo. The challenge with all of those studies is that none of them evaluated what the FDA now calls contribution of component. So you don't know if it was the induction portion or the adjuvant portion or both that actually led to the clinical outcome seen. So one of these studies has not resulted, and given it was the first done, we have to anticipate it to be negative. However, all of the others have universally been positive, not only in the intended to treat population study, but really across every subset. So every forest plot you look at trends in favor of the preoperative chemoimmunotherapy, of course, with the postoperative immunotherapy. The vast majority of these studies excluded patients with tumors driven by EGFR or ALK. In my own practice, that's expanded to include HER2, ROS1, anything else really not anticipated to respond to immunotherapy. The increasing benefit is clearly associated with increasing PD-L1 expression. However, if you look at meta-analyses, even the PD-L1 negative population benefits from this type of approach. But as I said, there isn't really a clear contribution of the adjuvant phase. A post hoc analysis was done of the two nivolumab studies, and the authors suggest that perhaps the additional of the adjuvant phase adds something, particularly in patients without a pathologic CR. However, that hasn't been prospectively demonstrated. And I'll counter that very quickly with the inconsistent adjuvant-only data we have seen. So in the adjuvant setting, meaning patients have upfront surgery, standard of care chemo, and then immunotherapy or not. There was one study with atezolizumab, really only positive in PD-L1 high tumors. There's a study of pembrolizumab, really only positive in PD-L1 low tumors. And then we have negative studies in the same setting, really showing no benefit irrespective of PD-L1, which of course raises question about that adjuvant component of the perioperative regimens too.
So a couple of sort of practical questions of just to pick up on the adjuvant, pure adjuvant patients who go to surgery first. In what situations, if any, right now are you utilizing adjuvant IO?
Yeah, I like the European guidelines on this topic best. PD-L1 0, discourage. PD-L1 low, consider. PD-L1 high, recommend. Now, the Pembro study was negative in the PD-L1 high population, really because it's a small population. It's about a third of patients, right? So you're downsizing your sample size there. But in that study and in others, we saw that PD-L1 expression is not only predictive, it's prognostic. So the patients in the control arm did very well. But I think if you take every other setting, we know that PD-L1 matters. So I would still offer in that or recommend in that setting.
And how do you define high? Is that greater than 1 or greater than 50? Really?
Yeah,
so in other words, under 50?
High in lung cancer is greater than 50, greater than or equal to 50. 1 to 49 is low, and less than 1 is 0, negative.
Yeah, no, I mean, I know that's the way it is in metastatic, and I'm kind of surprised. In other words, you're saying that if their PD-1 is not greater than 50, you generally don't use an adjuvant IO?
I consider. So I take into consideration everything else about the patient, including their smoking history, their NGS, which I will mandate before giving an adjuvant IO, their tumor mutation burden, and clinical stage risk-benefit.
And I'm guessing that you also involve the patient in sort of shared decision-making when you're not exactly sure which way to head. I'm sure there's some people who are very, very pro-treatment, some very anti-treatment. Is that kind of what you see?
Absolutely. And, you have to ask the patient if your cancer comes back in 2 years or 3 years and you don't take the immunotherapy, will you not forgive yourself? And it may be that that's when they choose to try a couple doses. And I would certainly say there's a very low threshold to stop.
So let's go back to the neoadjuvant situation because there's, to me, that's a little bit more questions there. And I guess I'm curious, first of all, how you decide whether or not to use adjuvant therapy after they've gotten neoadjuvant therapy. And also how this comes up all the time in oncology where you have indirect comparisons, different agents. You've got these different AIs. Can you kind of summarize what we know about each one of these AIs and whether you think indirectly there's any reason to favor one versus the other and what you actually do in your practice outside of a trial?
Yeah, I think all of the trials look fairly comparable. In terms of the drugs we have approved perioperatively in the U.S., it is Nivo was first, pembrolizumab thereafter, and durvalumab. It is the atezolizumab study we haven't really seen the data from yet. All of the data really shows that patients whose tumors demonstrate a pathologic complete response after induction therapy do exceptionally well. So there's no obvious benefit of additional therapy in that patient population. However, we have perioperative regimens, and they treated patients with path CR too. So if they've had absolutely no side effects from the immunotherapy, it's not unreasonable to continue. However, most of the patients have experienced something that would suggest it's not needed, and it could be added risk. For patients with purely viable disease after induction chemoimmunotherapy, I really don't think the adjuvant phase is going to do much. And for that reason, I'm using pembrolizumab in the clinic just because we have a study which escalates in the postoperative phase if they haven't had a path CR. If it weren't for that study, I'd have a complete confidence in using any of the available drugs. In terms of that middle ground, so patients who've had a nice response but not a path CR, that's where I would recommend continuing as long as they haven't had any dose-limiting toxicity.
You said you're doing a trial on escalating the dose of pembro?
No, it's an individualized neoadjuvant therapy trial. It's a randomized study. But
the mRNA study?
Yeah, it's the mRNA vaccines, but the study
Right, yeah, I saw that.
It mandates pembro pre, so we're sort of stuck with that.
Oh, I see. Yeah, no, that's really exciting. We could talk a lot about that, but any projections about when we might start seeing data from these vaccine studies?
Yeah, we anticipate seeing the melanoma phase 3, I think perhaps at AACR sometime soon, this spring.
Huh.
Wow. Melanoma, of course, is more immunoresponsive than lung cancer. In terms of the mRNA studies in lung cancer, the pure adjuvant study, I understand, is enrolling very well globally, but still we have to wait for maturity. Even in my own practice, enrolling after induction therapy has been very challenging.
Really? Is there toxicity to the vaccine, or what's the hesitancy?
No, it's having sufficient remaining tissue to both get what you need in terms of NGS and to create the mRNA vaccine. It's also in our patient population very common for our patients to have multiple primaries, which makes them ineligible for studies.
Interesting. What about ctDNA in this setting? You see any role based on what we've learned up to now?
I don't. Until we have better drugs, I don't think our assays are there yet to de-escalate with confidence. And until we have something else to offer, I don't know that knowing there is residual ctDNA really changes anything. You could see in the pure adjuvant Empower, the atezolizumab study, they did a ctDNA post-hoc analysis. They did the same with durvalumab. But my takeaway from that, with the assays they used at the time, that even in the ctDNA negative population, there was a lot of recurrences. So until these are better, I see them as cost with no benefit.
Right. Another question I have is related to this issue of, I guess, kind of why you see so much benefit in the neoadjuvant setting. It seems like, anyhow, to me, compared to the adjuvant setting. There's actually a famous study in breast cancer, NSABP did, B18, where they actually randomized between pre-op and post-op chemo, so neoadjuvant or adjuvant, and they didn't see any difference. But it kind of looks here like you do see a difference. Do you agree, and why do you think that is?
Yeah, I definitely agree. We did the same in lung cancer. The Spanish group did it, the NATCH study, many, many moons ago. There was a surgery only versus pre and post, and they were no different. But I take this from the melanoma data. Again, they're always way ahead of us in terms of immunotherapy, where they studied perioperative versus adjuvant-only melanoma and with a drastic hazard ratio for improvement in EFS. And it makes biologic sense here to incite an immune response, an anti-tumor immune response with both the tumor and the draining lymph node basin in situ. It just makes sense. If you're going to utilize the immune system, you need the immune machinery related to the tumor there versus a couple of isolated cancer cells floating around.
So before we go on to your next case, and what I'm really interested to hear about, which is management of localized patients with targetable lesions, maybe we just take a breath and also go back and talk a little bit about any advances in surgery, primary surgery of lung cancer or radiation therapy technique, anything that's come out or coming out of any great interest.
So if we compare diagnosis and treatment now compared to 20 years ago, removing the systemic therapies, what has changed? Preoperative staging has drastically changed in terms of utilization, universal utilization of PET scan and MRI, and invasive mediastinal staging. So when you look at all of the amazing adjuvant and perioperative data coming out of Spain, you have to keep in mind that they're so aggressive about mediastinal staging that they're capturing even the tiniest N2 positive patients, which is different than what we do here. I think in terms of surgical techniques, robotic surgery is really the rage. It seems that recovery times are faster and that the extent of nodal staging is better in terms of nodal dissections. If that will translate into survival advantage, I'm not sure we know yet. For radiotherapy, certainly IMRT is much better than the old-fashioned radiotherapy techniques, and we are seeing increasing interest in reinvigorating the idea of postoperative radiotherapy using proton therapy, proton versus photon. Of course, proton therapy having less toxicity, and toxicity is one of the main reasons that postoperative radiotherapy died after the lung art study in Europe. I'll bring up, a tidbit of data from ELCC just last week in Denmark. They presented an updated analysis of the Keynote 671 study with perioperative pembrolizumab, breaking the patient populations down with or without pathologic complete response. And in the intervention arm, the patients whose tumors did not demonstrate path response had a 5-year EFS of 43%. So in my eyes, that's really no better than Pacific. So we really need to figure out what to do with those patients who've had induction therapy and don't have a path CR. And that's where I think the modern radiotherapy techniques might really have a role. The Alliance Cooperative Group is running a proton port study, which I hope to be practice changing. Of course, we have to enroll it first.
So another question is about the surgery in the community setting. I'm curious what we know about the quality of surgery and also the acceptance of surgeons in the community, thoracic surgeons, to neoadjuvant therapy, delaying treatment. Now they're getting an IO. Maybe your patient had to have delay because of that. What do we see in terms of quality of surgery in the community and acceptance of the neoadjuvant paradigm?
I think it's a moving target. We always recommend that surgery, when possible, is taken care of by a dedicated thoracic surgeon who really understands the updated guidance on extent of nodal dissection, which is a moving target too. The guidelines are changing there. There does seem to be enthusiasm about the preoperative chemoimmunotherapy approach. I think the biggest challenge has been convincing community surgeons who for many, many years never considered N2 disease to be resectable to rethink about N2 disease and whether or not an induction approach in surgery may be appropriate. Certainly, we're in the process of updating the thoracic surgery guidelines, and really the overwhelming academic community recommends neoadjuvant therapy for any stage 2 or above disease. And I'm hoping that clearly stating these recommended guidelines will help support the utilization in the community.
All right, so this has been a great review, but I think the thing I really am curious about, and really started out at ASCO, although I've been wondering about this for a long time, is the issue of the management of localized patients who have targetable lesions, both adjuvant, which we've had out there, but now neoadjuvant. That looks very, very interesting. So let's hear about your 60-year-old lady. What happened with her?
Yeah, it's a nice woman I'm still taking care of who presented with a very large tumor, N2 disease, EGFR exon 19 deletion. And she presented while we were enrolling the NeoADAURA study. So she had a bronch biopsy of level 7, which confirmed both her disease and the EGFR mutation. So I met her at the time NeoADAURA was enrolling and really recommended the study. So NeoADAURA was a study of preoperative chemo, which would have been our standard of care, versus osimertinib monotherapy, open label, versus the combination, of course, placebo-controlled of chemo plus osimertinib. But the study, as ridiculous as it was, required not only a core biopsy, but central testing for EGFR, even though we've been doing this institutionally for 20 years. So that would necessarily lead to a treatment delay. She was actually less worried about the treatment delay and just didn't want chemo. So she was treated off-label with osimertinib with a near complete response on her scans. Pretty amazing. We don't actually anticipate this. This is a very, very good response.
Before you go on, I'm curious, 60 is pretty young. Why was she did she read up a lot about this? Why was she so strongly against chemo?
She's a healthcare professional and had her own opinions.
Interesting. Okay, but looks well she had a CR. Then I guess she went to surgery.
She did. She didn't like the wait times in the clinic of her surgeon at our institution and went outside.
Wow.
The surgeon outside started with a nodal dissection and took a frozen section from level 3 and thought it was positive. So he just wedged out the primary and didn't complete the dissection. She came back to us and the final path on that lymph node was negative. So what do you do now? We discussed her at the tumor board and she had repeat imaging, which was suggestive of some uptake in that, pretracheal lymph node there. However, she was recovering from surgery, really unclear. But she went back to the operating room for a completion lobectomy. I mean, she had T3 multi-station N2 disease and really had no viable disease in the lymph nodes. However, had a little bit of disease left in the tumor, so a clinical stage 1A.
What happened when she got the chemo?
She did fine. She just didn't want any more.
Wow, interesting. Also, I guess my question about community-based surgery is relevant here. This patient ended up having 2 surgeries. Do you think she should have theoretically have only had one?
Absolutely. I mean, there's really no rationale to spare a never smoker a lobe. She had known baseline N2 disease. The surgeon's perspective when he called me was that she's going to need radiation anyway, which is just not the case. So she should have had a lobectomy and a nodal dissection from the start.
So what's her current situation? How long has she been on osimertinib?
So we got to the 3-year time point, right? That's the question. At 3 years, both NeoADAURA and ADAURA stop osimertinib. And she had no nodal disease, so we should have stopped. However, she was uncomfortable stopping and really had very minimal side effects from osimertinib. So she has continued and interestingly developed a brain metastasis about a month ago.
Wow.
Probably more than a month now. She's probably 4 years out, four and a half years out, but developed a brain met.
Wow. Has she been treated so far?
Yeah, she was accepting of radiotherapy after much discussion.
What kind of radiation therapy did you get?
It was stereotactic. It was a very small metastasis. I think my practice with very limited data to guide it has been to obtain brain imaging annually on these patients. Sort of extrapolating from the LAURA study, where patients with EGFR mutant unresectable disease received chemoradiotherapy followed by osimertinib or placebo. And we really saw on that placebo arm a median time to relapse of 5.5 months. So this is a systemic illness. And we think a lot, are we curing these patients or are we delaying recurrence? And my punchline is usually I don't care. I would rather delay recurrence with such a well-tolerated agent until we have that data that we're curing folks.
What are you thinking about? I guess she does not have systemic disease. She just had an isolated brain met?
Correct.
And are you just observing her? Are you thinking about systemic treatment, trials? What would you do if she develops more disease?
Yeah, she's still on osimertinib. I think of resistance as being subclonal. And yes, of course, this one spot could be the tip of the iceberg and most likely is. But if it took 4 years for this to show up, it may take another year or 2 to see something else. So I don't see the rationale of added toxicity at this point.
So I'm curious, too, in this case, you continued beyond 3 years, but I'm curious about your thoughts in terms of cell-free DNA in general with targetable situations like this one. but particularly in terms of determining duration of treatment, do you think that maybe theoretically everybody should get indefinite treatment the way that was done in the LARA study? Do you think cell-free DNA should have a role?
So this is one case where I think eventually cfDNA will have a role. So the very small numbers of patients in the ADAURA study who had detectable ctDNA before enrollment, they invariably had detectable ctDNA again after discontinuation of osimertinib. I'll tell you the only place that I'm using cfDNA routinely now is for patients who are referred to me or self-referred, which is more commonly what happens with early stage EGFR or ALK-driven lung cancer, but not high enough stage to offer osimertinib or alectinib. For example, a T1C with high-risk features. So a tumor that's not high enough stage to give standard of care, but where if they were ctDNA positive, I would offer it. So that's where I am using it. For this patient population, I can tell you I had a study funded by AZ to do just that, to do a ctDNA-guided adjuvant study. But since ADAURA read out well before we anticipated it to, the study was closed based on the universal benefit. But I do think ctDNA here will play a role eventually, both in terms of duration and who needs it.
In terms of, quote, who needs it, it's kind of interesting. In breast cancer with endocrine therapy, started out with tamoxifen in the adjuvant situation. They eventually ended up using, because of the fact that generally endocrine therapy is so well tolerated, they use it adjuvantly in almost every patient with ER-positive disease, even very low-risk patients. And I kind of wondered, I know osimertinib, I don't know what indirectly how you'd compare toxicity to endocrine therapy, but to me it's similar in ballpark. And I always was curious why you all didn't go down lower, so to speak.
That study has completed enrollment a few years ago now, and I guess we'll see the results in the next few years. They did a stage 1. I think it'll be positive. Honestly, I was not involved, so I don't know what the enrollment criteria were. As long as they excluded minimally invasive adenos and really those pure ground glass lesions. But invasive EGFR positive disease, it's just prone to relapse. So I think it'll be positive.
So, have you been doing it yourself outside of trial? I don't know if you've had patients. You might have had a medical oncologist come to you as a patient. Have you done that, or have you stuck with the sort of the trial entry criteria?
The trial entry criteria of all the studies we talked about today, this is the only study that went down to 3-centimeter tumors. So they used the 7th edition staging, including stage 1B, which included 3 to 4 centimeter tumors, which every other study included. So if I had someone with a tumor less than 3 centimeters but other high-risk features, that's where I would offer a tumor-informed ctDNA.
So I want to get into the NeoADAURA study that you presented and other issues related to that. But first, just to continue on in terms of the sort of adjuvant targeted therapy. Obviously, we have ALK, with alectinib, but nothing beyond that. There's a new press release out with selpercatinib in the adjuvant setting. I guess nobody's going to be surprised. That's going to be a positive study. And it kind of just reflects the whole way, targeted therapy of lung cancer has gone, which is, you keep doing the same, you're doing the trials and proving that it works and not sort of generalizing beyond that. Do you think that we should keep doing this, keep waiting for phase 3 adjuvant trials? Or it's kind of like it seemed like in metastatic disease at some point, you cut back on the data you needed before you started moving it up to first line. Are there other, I asked a lot of people over the last few years, would you like to be able to treat RET? And almost everybody said yes. I'm sure you can make that argument. I don't know, maybe even for HER2 mutations at this point with the TKIs that are out there. Any thoughts about whether or not we need to keep doing adjuvant trials or whether we can just start using targeted therapy?
This comes up at a lot of our meetings, and I think each case is really risk-benefit, and we've exhausted our low-risk drugs. Even RET, I don't know that I would have clearly done it off study because of the notable risk of the RET inhibitors. Anything from hypersensitivity to hypertension to hypothyroidism. It's very different than alectinib and osimertinib, where, yes, pneumonitis is a risk, but it's easy to treat. ROS until taletrectinib, the ROS inhibitors were horribly toxic. I couldn't have imagined giving a ROS inhibitor off study, but taletrectinib is now being studied. So I think, yes, there are rare situations where a trial-ineligible patient should perhaps be considered for off-label use. But until then, I think we need to enroll these trials. So currently, there's a study of taletrectinib, there's a study of zongertinib, there's a study of zipalertinib for EGFR exon 20. We have a study of olomorasib for KRAS G12C. These are drugs where efficacy, for some of them, such as olomorasib, it's not like osimertinib, right? Efficacy isn't that great. I think we really do need to study it prospectively, understand the risk benefits before extrapolating from the data we have. Our two success stories are true success stories. The other drugs might not be as good.
So before we get into NeoADAURA in terms of neoadjuvant osimertinib, just kind of curious what's out there in terms of neoadjuvant therapy with other targetable situations, including ALK. Are there any data out there, any trials ongoing?
Yeah, I mean, all the data are largely single arm. There's two studies of neoadjuvant alectinib that have been presented, Al-Neo out of Italy, which only enrolled stage 3. So not everyone went to surgery. And then the Nautica study, it will be updated at World Lung, presenting all of the patients, whereas about half have been previously presented. It's interesting. We see much higher pathologic complete response rates with alectinib as compared with osimertinib. So it's really a good drug. I presented neoadjuvant divarasib at ELCC last week, just a small cohort, but we also see path complete responses in KRAS mutant lung cancer. So these are really interesting approaches, and I think all of the companies were super jazzed to put their drugs in the neoadjuvant setting until you think practically, both practically and mechanistically, if that really makes sense. And I don't know that it does in a prospective phase 3 setting. These populations are too rare. Finding them in a timely way is difficult. And then you have to ask, what is your endpoint if you're going to give the drug adjuvantly anyway? So I think most of the induction studies are small, signal finding, and maybe enable our extrapolation and use in rare situations. For example, right now I'm treating a very young woman with neoadjuvant alectinib while she undergoes oocyte harvesting. But it's unlikely to be universal, with the exception of EGFR, where it's just more common.
All right, let's talk about NeoADAURA, certainly one of the biggest trials in lung cancer, most important trials in recent years. Can you talk a little bit about the design of the study, what was observed, and also how what was observed compared to what you expected?
Yeah. So NeoADAURA was really designed to improve upon pathologic response. Understanding that we rarely see complete pathologic response with chemo in EGFR-driven lung cancer, we powered the study based on major pathologic response, less than or equal to 10% viable tumor cells in the resection specimen. And the statistical design was to look for a 20% improvement, either with OC or OC in addition to chemo. And we anticipated, based on data in part from my institution, that the MPR rate with chemo alone would be 20%. So looking to go from 20 to 40. What we saw is that the MPR rate with chemo was 2%. And while OC or OC plus chemo improved upon that, and it met its primary endpoint, we reached, 25, 26%, not 40, as we had hoped. So definitely appropriate and better to give osimertinib than chemo, or osimertinib with chemo. We still have a long way to go in this disease.
And in terms of your expectations, I'll tell you mine. I was surprised that chemo plus osimertinib wasn't better than osimertinib, like we saw in the metastatic setting.
Yeah, I mean, you have to wonder if that's the endpoint. Maybe major path response isn't the right way to look at this. Perhaps EFS will be different, although patients were permitted to get chemo after. But I was surprised too. I think based on FLAURA2, we were all anticipating to see a more deep and dramatic path regression with the addition of chemotherapy. And why we didn't, I don't know.
So currently, how are you thinking through your use of a neoadjuvant strategy in these patients? Does it change whether it's any risk factors, exon 19 versus L58R? And how do you decide whether you're going to use OC alone or OC plus chemo?
It's really based on the fitness of the patient, and irrespective of the plan, I always start with the OC as monotherapy and add the chemo if they're young and fit. I think the OC is what's carrying us here, and we could always give a little chemo post-op. So I think, to me, the most relevant data point from the study is that more patients got to surgery and had a complete resection if they had OC before surgery. So 8% of patients fell off of the control arm because they progressed or weren't resectable. So I think you need to give your best drug first. I would favor giving a combination of chemo and OC just because giving chemo pre-op is easier than giving chemo post-op. But for someone who's in their 70s, which happens to be, the main population in my clinic, we're just starting with monotherapy.
And patients ask you, how much more benefit am I going to get if I take neoadjuvant chemo? How do you answer?
I usually just explain to them the historic data. We know that irrespective of genotype, chemo lends a 5% improvement in survival. And I don't care if you get it pre-op or post-op. So we have to decide together what makes the most sense for the patient.
And what was seen in NeoADAURA, and what your thoughts in general about the results based on type of EGFR, whether it's exon 19 or L58R?
They both benefited from both approaches, either chemo or chemo plus OC. So for me, it doesn't make much difference what I'm treating pre-op. It's really, does the stage of disease need induction therapy or not? So generally for large tumors, N2 disease, anything where I think shrinking it will help the surgeon, that's when we'll give induction therapy.
So let's go on to your last case, a 67-year-old patient. What happened there?
Well, he's quite sick when he got to us. A 67-year-old former smoker, heavy smoker, presented with cough and dyspnea. He had an abnormal chest x-ray, which led to this imaging. And these are a few slices through his diagnostic PET scan showing a massive necrotic tumor, bulky lymph nodes, and contralateral supraclavicular disease. He had a bronch biopsy also showing 3C disease, T4N3. It was called NSCLC NOS, which we almost never call. We can usually point out a histology. But in the rare cases where immunohistochemistry doesn't point towards a diagnosis, it's NOS. His PD-L1 expression was low. His tumor mutation burden was 88, very high. And there was an STK11 mutation.
Was MSI testing done?
It was, and it was negative.
Have you seen a TMB that high in a MS stable tumor?
Rarely. In our very heavy smokers, sometimes we do.
That's really interesting. Mm-hmm. So what were your thoughts and discussions with him about how to proceed? Anything else from the workup?
There was not much else. I mean, his brain MRI was negative. He was actually hypercalcemic, which was a concern, but it did correct with fluids. And he was sick, so he just needed to start treatment right away.
So I see he got carbopaclitaxel and radiation therapy. What happened?
He got carbopac and radiation. His swallowing, his symptoms got much better very quickly. And I don't know yet if we've hit a plateau. You can see here his scan on the left from October and on the right from March. And they look pretty comparable. There's not much further shrinkage in that primary tumor, but clinically he's much, much better. So we'll continue. We'll continue a year of durvalumab.
Anything new in terms of date? I want to ask you about patients locally advanced with targetable lesions, but anything new in terms of these patients without targetable lesions? Any predictors of benefit? Any new trial concepts? Any ongoing trials you're excited about?
Yeah, it's really interesting. Pacific was a game changer, and every study they've done to try to recapitulate it has failed. So I think it works, and we give it, but we haven't found anything better. So the studies of concurrent chemo IO followed by IO compared to just chemo rads failed. So we really think of getting this under control with chemoradiotherapy the way we always have, and then giving the consolidation immunotherapy as a way to potentiate response and increase the chance of cure. But we worry about these patients, particularly someone with 3C disease, supraclav nodes. He got through this treatment amazingly well, which was a surprise given the size of the field. But I worry with a tumor that just looks as angry as that he'll have relapse. There's really not a lot new, frankly. We continue to see that increasing PD-L1 predicts outcomes, that irrespective of the enrolled population shows a survival benefit. But most trials moving forward, there are kind of two approaches. One would be escalating in the consolidation phase, and there are many studies activating to do so, looking at some of the new bispecific antibodies in the consolidation phase versus durvalumab. There have been some proposals out there to induce before chemoradiotherapy, but I worry a little about that based on the attempt to add the radiation to the chemo that didn't even beat chemorads with no IO. Beyond that, it's really, the buzzword at every meeting is borderline resectable. This patient was clearly not borderline resectable, which is why I picked this case. But should we be trying to convert someone from borderline resectable to resectable? And I would say I think I was enthusiastic about that until seeing that update from Keynote 71 showing that without a path CR, the 5-year EFS is in the 40% range. So I think we're not there yet in terms of knowing who we can convert from unresectable to resectable. So as old as the data is, this alone remains our standard of care.
I remember seeing I thought it was kind of interesting idea of adding things to durvalumab. I remember there was a study looking at I think it was called oleclumib and monalizumab.
The COAST study, right?
What happened with that?
The platform studies I've been a little resistant to be excited about because they're all far too small to find anything more than a safety signal. But there are a lot of full-fledged efforts to do this. I mean, TIGIT was in this space and it failed. But the bispecifics, particularly the PD-1 VEGF bispecifics, which are, I hope, not the next era of TIGIT where they all failed, but we'll have to wait and see.
So how would you have thought through this same case if the patient had an EGFR mutation?
Well, I could give you the data-driven answer or what I would do in my clinic. The data-driven answer is chemoradiotherapy followed by osimertinib indefinitely. For someone with stage 3 disease like this, I would give induction osimertinib. I think there's a lot of damage to the lung from a field this big, and if you can shrink that field and minimize toxicity to the person that this is a systemic disease. The same for ALK. We have very little data. There's a JCO paper largely out of Yale looking at retrospective use of alectinib in the consolidation setting. And in my own practice, if I can get away with it, I would do the same.
I think there was a trial at some point that didn't accrue, or there was a trial that was using induction targeted therapy. Maybe it was osimertinib and always made a lot of sense. And then...
Yeah, that was erlotinib and crizotinib. It was a cooperative group trial using erlotinib and crizotinib. Those drugs are they're not good enough, but it did make sense.
Yeah, I mean, if you can shrink the tumor, it makes sense in a lot of situations. I've heard there's another trial called NeoADAURA where they're actually going to use osimertinib, again, like you were saying, as induction before chemoradiation. Do you know anything about that study?
I don't. I haven't heard of it.
Yeah, Dr. Ramalingan told me about that. So, and yeah, apparently
he would know.
Again,
I mean, in my own practice, yeah, he knows. I wasn't aware of that study. And it surprises me, given OC's pretty old now, so I would be surprised they undertake that huge initiative. But in my own practice, I had a study approved to do the same with afatinib back in the day. And in 6 months, we found one patient who wasn't resectable. So the reality of EGFR-driven disease is that these are generally never smokers and they're not very symptomatic until they're sick. So it's pretty unusual to find stage 3 disease.
Although it seems like it would be nice to just shrink the tumor in general, make maybe less radiation toxicity. I don't know. Why not? It's pretty simple therapy, but I guess we'll see. I think this NeoADAURA study is only one arm, actually. Just I guess to sort of describe what happens, but I think that would be interesting. So
and that's what I do in clinical practice, and I have seen quite a bit of radiation pneumonitis afterwards. But I'd have to think that we've minimized that risk by shrinking the field.
In terms of other targetable situations, what are the targeted therapies that you will use instead of durvalumab in this situation? Starting with ALK, but also ROS1. I mean, any of the targetable lesions, where would you rather see targeted therapy rather than durvalumab, and you actually do it?
I really only have done this with EGFR and ALK. I've, in 15 years, only had one patient with unresectable ROS1 positive disease who got chemoradiotherapy. And that was in the pre-modern TKI era, but he's fine. He had an isolated cervical lymph node recurrence that was resected and radiated and struggled from radiation pneumonitis. But I can't imagine adding the toxicities of some of these other TKIs in this setting without measurable disease.
Again, any potential role for ctDNA in the locally advanced unresectable setting from your point of view? I know it's been looked at.
I can't see how it would really change my management. So I'm not using it. Perhaps reasonable if we could develop an escalation study design. But the same paradigm goes for me with these technologies. Until I have better drugs, I won't know what to do with the answer. It's just anxiety producing.
So a question I meant to ask you, which is, what are the clinical situations right now that you use neoadjuvant and the NeoADAURA strategy?
Yeah, I think the way I've spun it since the presentation is really anyone with EGFR-driven lung cancer who is appropriate for induction therapy should get a TKI with or without chemo. What is appropriate for induction therapy is really at the discretion of the surgeon. So in my eyes, if they have nodal disease, I think it would be reasonable to give. But if it's just a big primary tumor, I have sent some of these folks back to the surgeons. And interestingly, even with negative preoperative EBUS, most of them are upstaged. So the way I think about EGFR-driven disease, it really is a systemic disease. So the bigger the primary tumor, the more likely you're going to find lymph nodes. So we should really be thinking about induction therapy just to get these patients through surgery and to their adjuvant therapy, rather than flunking in the operating room.
So anything that we haven't talked about today, any papers that have come out, any issues in terms of all the different topics we've talked about today, anything else you want to bring up?
I think we covered most of it. I think one of the big considerations right now is knowing how to select a patient for induction chemoimmunotherapy versus chemoradiotherapy, especially with AstraZeneca and their MDT bridge study really looking at the ability of a multidisciplinary tumor board to make that transition. And I think the updated EFS data from ELCC really gives me pause that might not be the best approach for patients who would have classically undergone chemoradiotherapy. And unless it's really a PD-L1 high tumor in a patient with a tobacco history who really wants surgery, that we should still consider chemoradiotherapy our standard of care. I think that's my big take home from early 2026 in terms of data updates.
So I guess you're talking about the idea of making people who are unresectable resectable?
Yep. There is a big push. It comes up at every meeting, and I'm not sure we should be doing that.
Do you think people are doing that actually, in their practices right now?
Yeah. And there's even been a bit of a cowboy approach in some of the community practices where I'll see folks for second opinions who are clearly not medically operable, but the surgeon has said, just go get some induction therapy. They haven't thought about it. So we really have to be sure these patients are being discussed in a multidisciplinary fashion and that the right approach is taken up front. So if someone's on induction cis, gem, and pembro, I can't give them radiotherapy. We don't use gemcitabine with chest radiation. So we really have to be careful before diving into therapy that we're picking the right treatment paradigm for our patients.
Anything else that you see in second opinion in patients with localized disease that maybe would be good to bring up?
I see a lot of high risk stage 1, and I think that's still an unknown, right? A big empty box for us in medical oncology. But that's where I do think in the future we'll see ctDNA guided escalation trials that I hope will change the standard of care. Of course, we'll be talking about that in 10 years.
What do you see as the next wave of clinical trial ideas are being looked at in the localized setting, and where does cell-free DNA fit in?
I mean, unfortunately, there have been 2 MRD-guided adjuvant escalation studies in resectable stage 1-2 disease, and they've both closed with enrolling just a few hundred patients. I think using a combination of clinical characteristics to predict high risk and ctDNA will be the way forward in that patient population. In terms of, more advanced stage disease and de-escalation trials, I really hope we're getting there. I would love to not give chemo for a resected stage 2 if they don't need it. So that's where I hope the future will take us.
I hope we'll come up with better therapies, though, because, adjuvant chemo for non-small cell is not necessarily the most powerful therapy.
Well, perhaps it would
even
be,
with
though.
IO.
But what if we selected our patients better? If we eventually have ctDNA assays that tells us who needs it and who doesn't, then our number needed to treat is going to drop.
Well, that certainly would be great, but I just wonder whether or not there's enough efficacy there to really make a big difference.
That data I didn't mention was the NADIM adjuvant study. So this is, again, out of the Spanish group where they do very thorough nodal staging, and they gave adjuvant carbotaxol nivo versus carbotaxol, and the data is immature. They presented it at the first interim analysis, so it's not mature yet, but it looks really good. So perhaps we'll be able to salvage the failure of adjuvant IO by giving it with the chemo.
Interesting. And why do you think that's going to be positive when the other ones weren't?
I have to be honest, I think it's the Taxol and not giving Pemi. Pemi is a great palliative drug, but I'm not sure how well we're curing people. And again, it may be just giving it both together up front, where you don't have people flunking before they get to the IO phase.
Right. One final question. I remember when we first started talking about this many years ago, and you brought up this concept of major pathologic response, which is kind of different from what we've been hearing, outside of lung cancer. Can you talk a little bit more about how that's defined compared to PathCR and what we've learned over the years in terms of its predictive value?
Yeah, major pathologic response is less than or equal to 10% viable tumor cells. We have seen an analysis from Keynote 671 where they looked at residual viable tumor, and clearly it's almost a linear variable here, right? The more tumor you kill, the better. So major path response, it's a compromise, frankly, and it was proposed because we didn't have drugs good enough to induce PathCR. I mean, PathCR should be our gold standard, and there's a joint initiative between the International Association for the Study of Lung Cancer, the FDA, and industry to pool all of the data from the industry studies to really validate these surrogate endpoints as a standard. This is led by my mentor, Mark Chris, and Paul Bunn, and a few others. And I really hope that will move the bar. For NeoADAURA, MPR was really only used because we knew we couldn't achieve PathCR. So we'll have to see how these endpoints pan out in terms of the mechanism of the agent being studied.
Yeah, and breast cancer, again, outside of HER2 and triple negative, again, you don't see that much PathCR with ER positive. And there they have like a score based on an actual quantitative score to try to predict a prognosis. It's kind of like major path response, except it's more of a gradient. Has anything but like that been done in lung cancer?
It has, and it was sort of there's an inflection point, and 90% was chosen, or 10% was chosen really out of practicality. But I can tell you I went to all of the early stage breast sessions at ASCO for a few years while thinking about this and these study designs. And they're, of course, way ahead of us, as they always are in lung cancer. But that's what the RVT presentation by David Jones demonstrated, really, not linear, but looking at different cutoffs. And you see clearly the further you kill the tumor, the better the outcome.
Makes a lot of sense. All right. Well, thanks a lot. It was great. I really learned a lot. Appreciate your
Thanks for having me.
This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved by the FDA may be discussed, so check out the package inserts for more. Special thanks to Dr. Chaft, and thank you for tuning in. This is Dr. Neil Love for Oncology Today.